I'm just letting you know.
No, it's good. Hi, welcome to Hernia Hub. Today I'm very excited to bring you the expertise of my friend and fellow surgeon, plastic surgeon, Dave Straughan. Usually I do a better intro, but I actually don't know where you went to fellowship and stuff. Okay, full disclosure, I'm gonna call you Dave, but the audience can refer to you as Dr. Straughan.
Sure.
Okay. He was my chief resident at USF, and being a chief resident is kind of like having a lot of money or being drunk because it kind of shows you who you are as a person. And full disclosure, he was a very nice chief resident.
Oh,
I actually liked him a lot. I would never tell him to his face, but he's actually a really nice guy and a really good surgeon. So we did USF residency together where you finished general surgery fellowship.
Exactly.
And then, residency. Then where did you do fellowship and such?
I did plastic surgery training at Tulane in New Orleans. And then I did an extra year of facial surgery at Massachusetts General Hospital in Boston.
Cool. That all sounds very impressive.
I don't know about that.
Okay. So plastic surgery and hernia surgery have honestly not a ton of overlap, but the little overlap they do, I enjoy talking to you about it and kind of geeking out about it. And I think that there's some learning points that patients can take home with them, because having a abdominal wall hernia and needing a tummy tuck isn't a terribly abnormal situation to find yourself in. I actually probably get a few referrals a year from patients who have gone and seen a plastic surgeon, and the plastic surgeon told them, I can't do your surgery until that hernia is fixed.
Yeah.
Now, I know you and I work together pretty closely and we do those things together, but can you tell me like what a general, like a plastic surgeon's perspective on that is in general, you think?
Yeah, so in general, I think a lot of plastic surgeons that are doing tummy tucks are probably not wanting to do both at the same time, because it may increase the length of the surgery or maybe even increase somewhat the complexity. But we think it's best for the patient here at LRH to probably do them together, because one, it's just one anesthesia, one surgery, and the patients do really well when we do it. So honestly, because of our results, I think that we're doing the right thing.
Yeah, me too. And do you think the, not unwillingness, but like the fact that most plastic surgeons that are in private practice don't want to do it because they don't get reimbursed for it normally and it takes longer, it increases the complications?
Definitely all of the above. The idea that it takes longer, plastic surgeons, some people joke all they care about is money, but that is probably true for most plastic surgeons. So the longer they're delayed by watching you do a hernia, they're just losing money, honestly. So it's probably, quote unquote, not worth their time to do it. They'd rather just focus on the tummy tuck and get on to the next case.
Yeah, that makes sense. Do you have an opinion about large abdominal wall hernias and tummy tuck or any soft tissue reconstruction at the same time? Well, to back up, can you explain the difference between a panniculectomy and a tummy tuck / mommy makeover situation? Yeah,
I kind of think of it as a panniculectomy is an operation that is designed for women that have a lot of lower overhanging skin, and that can cause problems like rubbing and rashing. So a panniculectomy is designed to prevent that functional problem. Get rid of that lower skin so you don't have the rubbing and rashing. Insurance companies can pay for it if they think you're a good candidate. However, that's all it does. Mm-hmm. It's not considered a cosmetic surgery.
Right.
If you're going to do a tummy tuck, you're going to do more than that. You're going to go up higher so you can get more skin out. So maybe we can affect this upper abdominal skin, not just the lower abdominal skin. Plus, these two muscles that live here, they tend to separate when we gain weight, have babies. We put those back together when we do a tummy tuck, not a panniculectomy, to give a nice tight abdominal wall again. Plus a tummy tuck.
You're speaking of rectus diastasis.
Exactly, okay. Rectus diastasis, exactly. Plus, a tummy tuck can include liposuction, specifically out on the sides, to give more of a shape. Those additional maneuvers for a tummy tuck make it a cosmetic surgery. Not just designed to prevent rubbing and rashing, but designed to make you look better in your clothes, your swimsuit. And because of those additional maneuvers, it's not covered by insurance. Mm-hmm. It would be a cash operation.
And even when you try to get a panniculectomy covered under insurance plans, it fails often, right? Lots of denials for that particular operation.
Yeah.
What percentage of panniculectomies for insurance approval actually go through, you think?
About 50%.
About half.
And I would tell you, there are certain insurance companies that we know are more reticent to pay for it.
Good word.
And some are more willing to pay for it. But in general, it's about 50% all comers. But if they show the right reasons, mm-hmm. they're having significant rashing, they've been treated by a physician requiring, prescription medications to treat the rashes, and then we send pictures to kind of corroborate the story, I think that helps their case. However, nothing is guaranteed. And in fact, some insurance companies specifically have a clause where they deny all panniculectomies.
Mm. Would you do just a say that got denied, that request to do a panniculectomy? If a patient said, "Oh, I'll pay cash for it," would you say, "Okay, let's do it," or would you kind of urge them to do a full tummy tuck if you're going for all
Yeah,
that?
1,000%. I would say let's do a tummy tuck if we're going to pay cash, because depending on different situations, a tummy tuck could ultimately be a little cheaper.
Oh, really?
Yeah, because honestly, it's just a little bit of extra time in the OR. So I would definitely say, if we're going to be on the cash side of things, let's try to do a tummy tuck. I think it's better for the patient.
And if you were to make an estimate about how much a tummy tuck costs for just, if you averaged all general surgeons in the United States, what's an average cost for a tummy tuck?
Probably $8,000 to $10,000 with a few different things included. You know, how much suction you're doing and different things. But yeah.
Okay. Do you find that patients who try to get a panniculectomy paid for by insurance and then get denied, do they ever end up paying cash for that operation, or do they mostly just live with it?
Yeah, so I've had a few patients that have done that. And these were women that have had massive weight loss, i.e. lost 200 pounds or more from, you know, either bariatric surgery or the new GLP-1 drugs. And what that ended up doing on these women that are coming off the top of my head, it created an abdominal pannus of, you know, excess skin hanging like to the level of the knees. We're not talking about like a little extra skin after having birth, right? We're talking about women that have a devastating problem, and their goal is to literally just get rid of that. And I think those patients are the ones that are going to be paying for it, and they're probably not tummy tuck candidates based on their anatomy.
And when we talk about tummy tuck candidates, you know, I think one aspect where our jobs overlap is that optimization before surgery is really important, as well as preoperative expectations. What are some of your before surgery requirements to have a good outcome after, say, a tummy tuck?
Yeah, so when we're talking panniculectomy versus tummy tuck, that would be different. So when I talk about a panniculectomy, I want it to be a safe operation. And my goal for a safe operation, obviously you need to be medically optimized just like for your hernias, but we find that BMI of 35 is kind of that area where we want them to be below, because then we know that their risk of complications like wound dehiscence, infections, you know, dead skin, things like that, it tends to go down with a BMI of less than 35. So when we're talking about a panniculectomy, that's kind of where we're going. You know, we want this to be safe. Tummy tuck is a different story. Tummy tuck, obviously we want it to be a safe operation, but we want the cosmetic goal to be better. So I always tell people, this operation, a tummy tuck, is a skin removal surgery. It's not a weight loss surgery.
Yeah, I do think there's a big misconception about that.
Precisely. So I always tell my patients, if you're going to pay me $8,000 to $10,000, you obviously want a good result. And I always tell people, if you want that good result, the more work you do on the front end, the better the result's going to be on the back end. I.e., we're not talking about a BMI of 35. We want to get that BMI as low as we can get, because the more fat you can lose, the more skin I can excise. And obviously, the tighter the look and everything like that.
It'd be awful if you got a tummy tuck at a BMI of 34, and then you lost a bunch of weight. Now your BMI is 26.
Oh,
and you have all that extra skin afterwards.
Yeah, I always tell people, we want to get you to a goal in stable weight before surgery rather than after surgery, because God forbid, just like you said, you lose a bunch of weight after surgery, you'll be dealing with extra skin after the surgery. Nobody wants that.
Yeah. And how long would you wait after delivering a baby and say you were done having kids? You would not do any reconstructive abdominal wall if you wanted more kids, right?
Yeah, ideally you wouldn't, because if you're going to plicate and things like that of the rectus diastasis like you talked about, we don't want to do that until after we're done having babies for obvious reasons. I wouldn't do a tummy tuck until we're at least 6 to 9 months removed from having a baby. And we also, again, want to be at a goal and stable weight. So we don't want the weight loss to be going down. We want to make sure we catch it at that stable weight.
Yeah. I was thinking anywhere between like 6 months and 12 months to let the abdominal wall come back together to where it's going to be.
Precisely.
Because everyone has diastasis after you deliver. Everybody.
Yeah.
Right? It's how much is it going to come back together, which I don't really know why some people come back together and some don't. Just
I don't know.
Genetics? I don't know.
Probably genetics, yeah. And I've had women that they're like the smallest people in the world, and then I go in to do a tummy tuck and their muscles are, you know, completely splayed apart.
Right.
And I can't explain it.
You know, it's interesting because we both deal with rectus diastasis, which I think is like a super fascinating pathology that like we're just kind of like get at the tip of the iceberg of knowing who to treat and how to treat them. Because we don't have great criteria for who should be plicated, bring the muscles back together. And there's no agreement on if mesh should be used, what type of suture, meaning permanent or absorbable, should be used. We all have our preferences for sure, but there's no studies that say like this is the right way to do it. Otherwise, everyone would do it the same way.
You're exactly right. Whenever there's a lot of different ways to do something, it's because nobody knows the right way to do it definitively. Now, in my practice, I have learned from my mistakes. So when I do a muscle plication, I used to use Prolene sutures.
Like
That's
a permanent suture.
A permanent suture, non-dissolvable. And I ended up having to go in a few patients and take those sutures out.
For what reason?
Spitting, sutures coming out, or a little draining
tract sort of
sinus.
thing?
Exactly, yeah.
I have a strong proclivity for hatred of Prolene as well.
But the idea is we use the Prolene because we want it to be a permanent fix, right? So it makes sense. So I stopped doing that, and now I use a barbed PDS, which is a longer acting dissolvable suture.
The Stratafix symmetric?
Exactly.
Which is 180 days? Dissolvable?
Exactly. And I think that by then we have scarring that happens. So even if the suture does dissolve at that point, I think the scarring should be there to hold everything together. Now, I've not had any women come back to me, 3 years later and be like, oh, geez, look at my diastasis. I've also have not done a study on getting CT scans post-operatively to see what happens, but I've been much happier with the PDS version versus the Prolene version.
Yeah, that totally jives with my opinion that is completely anecdotal as well. Because I also think that the permanent sutures act like sort of like a cutting seton and pull through that tendon and that muscle and that fascia, but it's all theoretical and
nobody knows.
Yeah. But no, I agree. Our job is to put tissue together, and your body does the fusion of that tissue long term, and whether or not we use permanent or resorbable suture probably doesn't add a ton to the equation.
Probably.
And so, I know you talked about wanting to get down to a goal weight to be happiest before a tummy tuck, but do you have a number? Like, do you have a BMI cutoff that you would not do?
For tummy tucks, you mean? No, so tummy tuck, obviously we want to be less than 35 because we know that number is safe. But I always tell people when at tummy tuck, it is very individualized, because if you're shaped like me and you have a little extra tissue here, you're
being a little mean.
Yeah,
I think you look great.
You may be at a weight that seems okay, but you still have extra adipose tissue in your weight, as opposed to some people, when they lose weight, they lose it immediately from their abdomen. So I always tell people, ideally we'd get less than 30, but I want to take a look at you at less than 30 just to see what your abdomen looks like.
Right, that makes sense.
It's more individualized.
And do you think that's kind of the algorithm for most plastic surgeons in the community, like private practice? How is that different from what you do?
Well, I love my surgeons, my fellow plastic surgeons in the area. I really do, and they're very good. But if you go outside of our area, I will tell you there are some surgeons that are looking to just take your money.
Meaning they'll do the surgery at a higher BMI.
Yeah, because they're not necessarily caring about what your ultimate look is going to be, or if you're going to be satisfied. It's just, let's get the surgery done and let's get her out. That's not the way I feel. I want you to be happy. I want to be happy. I'm only happy when the patient's happy. So I know the things we need to do beforehand to get there.
And what percentage of tummy tucks would you say in your practice are done on women opposed to men?
I would say 98% are done on women.
Sure.
I actually randomly was at one of the other LRH facilities yesterday, not my facility, doing something, and I saw one of my male tummy tuck patients in the elevator.
Yeah.
And
happy?
I obviously, very happy, but I knew exactly who it was because I don't do them that often,
Out of all the surgeries you do, which type of plastic surgery reconstruction are your patients most happy about, thankful for?
Well, breast reductions.
Really?
By far, yeah. Breast reductions, different topic.
No, yeah, talk about it.
Don't want to spend a lot of time on it, but breast reductions, women come in with very large breasts that are basically causing them neck pain, back pain, shoulder pain, rashes under their breasts. And they've been dealing with this for, 20 years, 30 years. Immediately right after surgery, they get a relief. And they look better too. So it's kind of one of those win-win things, cosmetically and functionally.
Yeah, not like the panniculectomy, which is complete, not a cosmetic operation.
Not a cosmetic surgery.
This kind of gets you both, which is rare.
Yes,
And insurance usually pays for reduction?
Also about a 50-50 shot.
Really? That's sad.
Yeah, the insurance companies, they tend to call everything cosmetic, even when there are definite functional benefits to what we're doing. And I think that is part of the problem with rectus diastasis specifically. Because there have been studies showing that you have functional benefit from repairing rectus diastasis.
That was going to be my next question for you, is about rectus diastasis, which I'm also passionate about, is do you think it's purely cosmetic?
No, I don't.
Either.
Because I've seen women, kind of like I was talking, I did a tummy tuck on a lady. She probably, very small woman, probably weighed 110 pounds, but just a gaping rectus diastasis. And
she'd had children?
Had 3 children, actually. And no matter what she knows or what she thinks, there's no way her core strength is what it used to be, because those muscles anatomically aren't even where they're supposed to be.
Right.
How is she going to have the same core strength that she used to have?
I 100% agree.
So I think there definitely is a functional component, but to convince insurance companies is a whole different thing.
Yeah, and a lot of that like cosmetic abdominal wall opinion, I think, is leaking out into the patient population. Where I have patients come to me with like a pretty bad abdominal wall hernia, like a legitimate hernia, and they're like, I'm worried my insurance company won't pay for it because this is a cosmetic problem. And I said, this is not a cosmetic problem at all. It's like something 100% that your insurance should and would cover. But rectus diastasis is not covered by insurance. There's no scenario where if you don't have a hernia, that they would pay for your rectus diastasis to be repaired. I think that if you have an abdominal wall hernia, the best thing to do is bring everything back together, including the diastasis. But it's probably a minority opinion amongst general surgeons because it takes longer and it's not reimbursed.
And we do that when we do our joint cases. If someone's got a hernia, we'll fix the hernia however you see fit, and then we will tend to plicate over top of that, not for a cosmetic reason,
Sure.
but it reinforces the hernia repair. And do they get a cosmetic benefit by bringing in the yes? But that's not the reason we do it.
Yeah, and I think there's a lot of different ways, because when we started doing this together, meaning a tummy tuck plus a hernia repair at the same time, it's kind of, in a way, it's an ideal hernia repair because like everything is completely exposed. I don't think people understand like how incredibly just like wide open your abdominal wall is during a tummy tuck, where if you have any hernia at all, we will see it, and there's no better time than then to fix it.
1000%. It would be silly, and I do know some people do this, to do them, robotically, and then go back after that with a tummy tuck. Because, like you said, no time is better than when everything is completely out for the surgeon to visualize everything and have exposure to everything, like a tummy tuck.
I do think that if it's a plastic surgeon in the community that you've already decided to go with, and they said you have to have this hernia fixed beforehand, that scenario, I do think it's better to do them from the inside because you're not messing up any of that like anterior abdominal wall anatomy.
Yeah, that's not what I meant. Yeah, I mean, if you don't want to undergo two different surgeries, two separate anesthesias, double your risk of all that stuff, then yes.
And I think that even like groin hernia exposure is actually pretty good from what you're doing.
We've done that.
We've done it, yeah. And I think it's nice for me. It's kind of like the easiest hernia repair of all time. You've done all the work.
I've gone in there and done my dissection and inadvertently found a groin hernia, and I called you in and you were able to fix it. So that woman definitely got a benefit from that. But you're right. I mean, it's better than trying to do this through a separate small incision. Yeah. Everything's completely out. All the anatomy's out and it's visualized.
For sure. And then I know we talked about BMI cutoffs, but do you do a smoking criteria at all for any of your plastic surgery reconstructions?
Yeah, so I don't. For elective surgery, which all of this would be, when I say elective, I don't mean cosmetic. I mean non-emergent surgeries.
Yeah, because Dr. Straughan also takes emergency plastic surgery call at our hospital for traumas and reconstruction. Yeah. That's not what we're talking about here.
Yeah, so non-urgent cases, elective cases, I do not do with people having nicotine in their system because the risks are way too high, right? The nicotine will constrict your blood vessels and prohibit you from getting blood supply to the tissues that need it to heal. Right. So that's how you get wound issues, infections, dead tissue, things that you don't want to deal with. So my criteria is you need to be nicotine free for 6 weeks before surgery and 6 weeks after surgery. And I do a nicotine test in my office just to make sure it's out of your system.
Oh, really?
Yeah, because some people, it's how quickly you metabolize it.
Sure.
Right? So like the average is 6 weeks, but you may still have it lingering in your system after 6 weeks. And we want to make sure it's all flushed out.
Right. Yeah, we have similar goals for hernia surgery where we want to stop smoking. We usually say 4 weeks before and 4 weeks after. But to be honest, plastic surgery has always been a little bit ahead of the game. And with surgical optimization, I think we could continue to take pages out of their book to make our outcomes better.
Yeah, I've looked into this, and there's really no specific data to tell you. People say it's 4 to 8 weeks is what the studies would show. Yeah. So I went to
pretty big range though. If someone like really can't stop smoking, between 4 and 8, I think is pretty big.
And the other thing that we need to talk about for smoking is, I used to just ask people, "Do you smoke cigarettes?"
Right.
And they would say no. And now I've found myself asking
what do you ask now?
Very specific questions. Do you smoke cigarettes? Do you vape with nicotine? Do you wrap marijuana with cigar papers? These are the things that I didn't even think about when I started my practice. That people are like, yeah, I smoke blunts, but then I say, oh.
Well, what do you wrap with?
Yeah, exactly. So these are kind of, I figured this out because people don't even know they're using nicotine.
Right.
Some people think vape is nicotine free, right?
Right, yeah.
But it's the nicotine that's, because people are like, well, at least I'm not smoking cigarettes. That's great. But it's the nicotine that's the problem with surgery more than it is the tar in the cigarette.
Sure, yeah. And what better way to get to know your patient than know what they wrap their blunts with, Is there say someone had a very large abdominal wall hernia, would that change your mind? Like say it's like a 10 centimeter or greater defect. Would that change your mind about whether or not you would do a tummy tuck at the same time?
No, honestly, the reason I say no is because
No, it wouldn't change your mind.
no, it would not change my mind. I'm sorry. I would still consider doing it, assuming the patient, well, a few things. One, is the hernia repair going to take an exuberant amount of time? Is it a complicated operation? Because if that's going to take 6 to 8 hours, I'm not going to add on a 2 to 3 hour operation on top of it.
Yeah, 12 hours of anesthesia is not good for anybody.
Precisely.
Yeah.
So assuming that that's not the case, I think that's a great time, because once we do that and you take that large abdominal wall hernia and bring it back to the midline, by definition, you're going to create extra skin by basically bunching up that skin. So that's a perfect time to undermine and get it all out.
Yeah. What do you say the biggest diastasis you've ever plicated was?
It's that same lady I was talking about that had 3 kids that was like 110 pounds.
And she's a small person in general, so like the ratio of that to her abdominal torso is pretty significant.
Yeah, it was completely just almost ripped apart.
Have you ever seen abdominal compartment syndrome from diastasis
Yes.
plication? Tell me about that.
When I was a fellow at Tulane, I was not involved with the case, but one of my attendings did a tummy tuck, and she got admitted overnight. I can't remember why. Wasn't able to pee or something like that after surgery. It's not usual to have someone admitted after a tummy tuck.
Yeah, most time a tummy tuck or any cosmetic surgery really is a go home the same day.
Precisely, yeah. Anyway, so I was actually on call, for the hospital or whatever. It wasn't involved in
I'm
the
excited
case.
to see where the story goes.
Yeah, so I went in and saw the patient. I did general surgery residency, and I was just...
And you were good at it.
And I was just removed from that. So come in, the lady's not urinating, blood pressure is a little low, she's just not doing well. So we actually diagnosed her with abdominal compartment syndrome, and at the bedside we opened up her incision and was able to open up the plication stitch.
Really?
Yeah, and she got immediately better.
Like intubated in the ICU situation?
Yeah.
Wow. That sounds terrifying.
Yeah, so I mean, these surgeries aren't to be taken lightly, right? I mean, it's still surgery.
That's why we optimize.
Yeah, exactly. That's why preoperatively we're going to make sure the patient's the right candidate. Not that this patient wasn't the right candidate, but when you talk about that, like, we're like, hey, if putting it together is good, putting it together a little more is even better. So you have to know what the right answer is, because you can hurt someone doing these things.
Because some people over-plicate on purpose, right? They don't just bring medial edge of rectus together. They do even more.
Oh, yeah.
Do you have an opinion on that?
And I do that.
You do that? Okay.
Yeah. And I basically...
Hernia surgery, we just bring rectus together.
Well, no, what I do is I want to get rid of some of the abdominal wall laxity, and I think of it as like an internal corset. So I can get more of that tissue in. But while I'm doing this, the first thing I ask the anesthesiologist is, what is the peak airway pressure before I start?
Meaning, how much is the ventilator working to push against the pressure of the abdomen?
And then as I do it in multiple layers, because that's the way I do it. And
that's what I think most plastic surgeons do. That's the difference between plastic surgery, abdominal wall, recon, and general surgery. General surgery is mostly a one-layer closure.
Yeah.
Well, we use mesh, and plastic surgeons usually don't.
Yeah, I do not use
So
mesh.
2 different ways to get, and your literature is actually very good for recurrences and such.
Yeah.
So I don't know what the right answer is.
But regardless, I'm talking to the anesthesiologist, and I'm saying, is the peak airway pressure going up as I finish the first layer? And then if not, it hasn't changed at all. Then for the second layer, maybe I'll plicate a little more if I can get away with it.
Sure.
And certainly, if for whatever reason they are concerned about the peak airway pressure, I'll cut it out and do it. Maybe not
There's
even
one
do it.
layer less.
Exactly.
Kind of thing.
Which has never happened in my practice.
That's because you're careful. The last question I'll ask you is, there's a big push in the general surgery hernia community now for general surgeons to do their own soft tissue reconstruction during their hernia repairs. Meaning, patient has a lot of extra skin, so they're going to do a large open abdominal wall hernia and do a panniculectomy / some degree of a pseudo tummy tuck at the same time. Do you have opinions? I personally do not do this, so my feelings will not be hurt. I think that plastic surgery should be left to the plastic surgeons, but what do you think about that?
Yeah, I mean, I did 3 years of extra training to learn how to do this appropriately, and maybe even have a few tricks that some people don't have from the general surgery background. So if you have the availability, I certainly would, because it's not as simple as making a large midline incision and then just kind of bunching up skin and cutting it out. That doesn't tend to look good. You need to know what you're doing as far as...
I think that's what the majority of general surgeons are doing in that scenario. And they'll use that as a way to justify doing an open surgery or over minimally invasive surgery, which I don't think that's our place, truly.
Yeah. Yeah, no, I think a plastic surgeon being involved, because each patient is unique, their body type is unique, their amount of laxity and which dimension that laxity
And even the bed positioning, stuff that you do that I just don't even think about, like sitting the bed up so you can get a tighter pull down.
Yeah,
those are not things that I do or think about.
Yeah, again, different training. I am not going to be doing robotic hernia repairs. That's not something I'm going to be doing.
Thanks.
Not trained for it. and some of this skin tightening procedure stuff, like I trained for it, so I think that it's probably best left in the hands of a plastic surgeon. This is coming from someone that's board certified in general surgery too, right? So
you still have it?
Yeah.
When are you going to give it up?
2028.
Oh yeah, when you have to recertify?
I have to retake a test.
That makes sense.
Yeah. So anyway, I think that there are general surgeons that are very good at this kind of stuff, but if you have a plastic surgeon available, probably in the patient's best interest.
Yeah, that works for me too.
Yeah.
Hi man, thanks for talking. Appreciate it.
Thanks. Appreciate it. Awesome.